Right,
Okay.
let's get started. If there's still people joining, that's absolutely fine. We're just going to do some introductory stuff first. Yeah, let's go.
Okay. So nice to virtually meet you all. My name's Holly. I'm a doctor working at Aintree. I went to the University of Manchester. So I've stayed around the Northwest from my training and for my first job. I'm the Vice President of Thursday 15.
My name's Alex and I work in Liverpool at one of the hospitals called the Royal. I trained in Bristol and absolutely loved it, but I'm from further north originally, so I thought it was time to come back up a little bit. Really enjoying it, yeah. And I'm the tutor lead for Thursday 15. And we've put together as a committee a session on the PSA, a mini series, which involves 6 lectures, and it's just us giving you guys some tips, some questions and some hints, some things that we found useful when we were revising.
Okay, so I'm not sure how many of you have heard of Thursday 15 prior to seeing this talk, probably advertised on Facebook and coming along, but we are a group of 7 junior doctors in the Northwest. And 5 of us are F1s, and this committee was created last year with an aim to help facilitate revision sessions for final year students. So what we're wanting to do as a committee this year is a PSA series, which we're currently on session 2, a final series which started last week, and that's running every Thursday with the PSA sessions running on Tuesdays. And the unique experience of Thursday 15 talk is that we will start with multiple timed questions, very similar to the exam in an MCQ format, and then we will use the answers to those questions in order to try and teach you a little bit, hopefully.
So a little bit about the PSA. So as you guys know, the PSA is an exam that you have to sit before you're able to prescribe as an F1. It's a really important exam, but I think you get a few chances at it, so that's good. If you're feeling nervous, don't worry about it. It's not one of the most important ones you'll sit this year, probably. It runs 8 sections and it's over 2 hours. The key thing that's difficult in the PSA is timing, so it's quite time pressured. You do have access to the BNF and you have access to the online version and the paper version. I think pretty much everyone in my year used the online version. It's just a lot quicker to get through. So it's really important that you know how to use the BNF and where everything can be found. So spend some time familiarising yourself with it. Key things about the exam: if you don't know something, you can flag it for later. That's a really helpful tool that they give you. And we found the practice papers on the BPA website quite helpful. I think a lot of other places do practice papers, but those are the questions that you will be getting, and that's what we've tried to model our questions on as well. So hopefully you'll find that they're similar, and hopefully they'll be helpful as well.
Cool. I'm also keeping an eye on the questions that are in the chat, but there's quite a few of us here today. So if we don't answer straight away, we will get round to it. We'll just be occasionally checking in. So hopefully we've just answered one of those questions about where we could get the PSA past papers. So it's either the BPA official website or the QuesMed is the other website that we've answered. Regarding your questions about last week, we'll come on to deal with those later.
So the first section we're going through today is prescription review. So this will encompass 8 questions in your exam with 4 marks each. So you'll see examples as we go through, but each SEM has a list of 6 to 10 prescribed medications with the doses and when you take them. And then there's 2 questions asking you about the prescriptions. So about interactions, side effects, and drug dose and frequency errors. So it's important to look at all the prescriptions really carefully to spot the errors. We recommend 20 minutes for this section, and we'll be going through about 2 minutes per question, so one minute for each part A and part B in the STEM.
Okay, planning management only has 8 questions that are 2 marks each, so it only actually makes up a really small percentage of the number of marks that you'll get in the exam. They're a single best answer style, so you've got to choose the most appropriate answer from 5 options. We are thinking of holistic management of the patient, so the most appropriate management step might be to not treat the patient at all, or it might be using non-medical approaches. So just bear that in mind when you're considering what the most appropriate answer would be. Recommended timing for all of the planning management questions is about 8 minutes for all of those questions.
Just to answer a question in the chat, just for those of you that arrived late, so we will be sending the recording and the slides out afterwards. So how it works is there'll be a feedback link at the end of the presentation, and when you fill in that feedback link, we'll send you the slides and the recordings. So that's how you get them. So back to prescription review. So really important things to learn. So common side effects for drugs, so stuff that like electrolyte imbalances, so learning what medications cause hyperkalemia, hyponatremia. You'll have seen quite a lot of it on the wards, and it's the same sort of drugs they tend to use, so it's really important to learn those. Also learning what side effects different drugs have, and often if there's 2 drugs with the same side effect, those are avoided together. And you can find side effects in the BNF as well. And a good question they ask as well is which drugs should be stopped before surgery, so in the procedural period is what it's called. So just having a look at that is really good. If I was to give you a tip for prescription reviews, I think when you read the question, sort of have in your head already what you think the answers might be. So if it's a question on a drug that might cause gastrointestinal bleeding, already have in your head, okay, I know these drugs do, I know these drugs do. So when you look at the answers, you don't get sort of misled by what they might have. Yeah, and look at each prescription carefully. So even if you think you've got the answer after looking at the first 2 prescriptions, go through all of them, because there might be one that fits it better than the one you originally picked.
So some common drug errors to spot when you're doing prescription reviews are trying to learn which drugs are prescribed in micrograms rather than milligrams. It's a really common thing for the question writers to write it in the wrong dosage, and you might not spot it because it's the right number at the front, but you don't actually consider the units at the end. Similarly, in terms of doses, it might be a power of 10 error. So for example, giving 10 grams of paracetamol rather than 1 gram of paracetamol, obviously that is definitely a drug error. Or the dose might not be correct according to weight. So that's particularly when you are prescribing certain IV antibiotics or when you are prescribing for children. That might be when you just want to check exactly what dose would go with the weight of that patient. And some drugs are usually prescribed weekly, but might be prescribed at the correct dose for a weekly dose, but prescribed as once daily instead. In order to find side effects quite quickly on each drug's page, so for example, if you're looking for hyponatremia, hypokalemia, use Control F when you're on that drug's page instead of having to go to the side effects section. Obviously, it's really quick to click on side effects, but you can have that preloaded in Control F and just cycle through the drugs in order to find that side effect quickly.
Another thing you can do, which they didn't tell us before our exam, is you can, if you know how your computer split screen works, you can split your screen so you can have the exam questions on the left hand side and the BNF on the right hand side. So when you're doing the questions, you already have the BNF there, and you can like use the function, the Control F, to find bits of information really quickly.
Well, so in terms of planning management tips, as I said before, the most appropriate treatment might not actually be any of the medication that's on there. It might be something like TENS machines, or no treatment at all, or physiotherapy. Usually in these questions, the questions are alluding to a diagnosis, but won't explicitly say what the patient has been diagnosed with. And you have to use a little bit of clinical knowledge to sort of diagnose the patient. It's usually fairly obvious, but then try and work out from that what the most appropriate treatment is. It will always have the past medical history and the drug history included alongside potentially patient observations or recent blood tests or recent imaging. You might not need all of this information, but it's good to check through, because quite often they might have a deranged renal function, they might have an AKI, or there might be allergies or other comorbidities that you need to be aware of. Just make sure you look through all of the information, because even though a drug might be first line for someone who is usually fit and healthy, it might not be first line in that patient that you are prescribing for. In order to try and find the most appropriate drug, you may already know what the treatment is for the specific condition, in which case just search for that drug specifically. Or if you don't quite know sort of order in which, you know, first line, second line treatments for that condition. You can search for the condition itself, and annoyingly they've put some of the conditions as slightly strange wording within the BNF. So for example, if you're looking at a patient who's had an overdose, type in poisoning, because apparently that makes sense.
Just to answer a few of the questions that I can see. So are trade names used? They shouldn't be. It should be the generic name of the drug, but if you type the trade name into the BNF search bar, it should come up with the medication. So if you type in, so paracetamol, and then if you type in Panadol, which is I think the brand name, paracetamol should come up. I'm not sure about that, but they should use generic names rather than brand names. Do you sit your exam on your own laptop or the uni computer? I don't know how it works for different universities. In Bristol, we sat it on a uni computer. So if you can practice using the computer you might be sitting on beforehand, that'd be good. For that one, the split screening was like old Microsoft, like 2006, I think. So it's just like a minimize icon in like the top left-hand corner, I think. So instead of like exiting or like minimizing right down to the bottom, you had an option that you could just sort of minimize it to a little box, and then you can just move the screens where you want them on the page, on the screen even. Yeah, and you are allowed to use Medicines Complete as well. Yeah.
And the benefit of Medicines Complete, I'm not sure whether you guys have found the Stockley's interactions checker, but it's a really good function that you can use. You type in all of the medication names and it will work out if any of them interact for you. Obviously, that's not as applicable necessarily for these sections that we're covering today, but it's a good thing to bear in mind. In terms of Control F, if you literally on a Windows computer hold Control and tap F, you can find something that's on that page. Just going to move. Oh, apparently Stockley's is banned for us this year. Oh, sorry guys, that was we obviously lucked out last year.
And then on a Mac, it's Command F instead of Control F.
Okay. We'll just move on for a second. I can see that there's some questions building up, but if we get through to the questions, and then we can work on trying to type in some answers to your questions whilst you're all doing the questions. So just something else to discuss while we're on the planning management section. So a common question is about palliative care. So I would advise that you go through common palliative care drugs. There's a prescribing in palliative care section on the BNF. I think it's best if you just go away and look at that in your own time and look at what the common drugs that are prescribed for secretions, agitation and pain are. But another section to that is about learning to convert opioids. So you go on to the prescribing in palliative care section, and then I think it's something like pain relief or opioids within palliative care. And it sort of takes you through converting between one type of opioid and another. So you might be told how much of codeine and Oromorph someone is taking in a day, and you might be asked to sort of sum that all up and work out how much background pain relief that these patients need. So pain relief is split into background, which is sort of longer term modified release formations, and that will be a bigger dose, and then we'll have a smaller dose of breakthrough pain. So some useful sentences that come from that prescribing in palliative care section of the BNF is that the dose of the breakthrough pain should be 1/10 to 1/6 of the regular 24-hour dose, which can be given every 2 to 4 hours as required. So if for some reason a patient was on 60 milligrams of morphine, their breakthrough dose would be 6 to 10 milligrams. And as long as you prescribed within that range, any dose between that range should be fine, according to the BNF. And then when you're adjusting the dose of morphine, you need to add up the breakthrough dose and then how many milligrams in PRN breakthrough doses they're getting. Add all of that up, convert it all to morphine, because it might be they're having some as codeine or whatever. And then you increase the breakthrough in sort of 1/3 to 1/2 increments. So 1.5 times that sum total that they've had, if that makes sense. Okay, And this is just a table that I was on about that sort of shows you the equivalent doses for different types of opioids. Okay. Alex, anything else to add?
No, I think that's all covered. Yeah, try and get your head around prescribing opioids. It can be really difficult, and it's something that still tricks out doctors as well. But yeah, that table that Holly's provided is really helpful. And if you have a bit of a read, it should be clear.
Okay. Right. So what we're going to do is we're going to do 20 minutes of sort of practice PSA exam that's just solely prescription review and planning management questions. So there'll be 10 prescription review and 10 planning management questions. We're going to do 2 minutes a question for the prescription review questions and 1.5 minutes for the planning management questions, just because they're only one part and they're a little bit shorter. This is a learning session, and obviously you're not going to be able to get a chance to go back a question once we've progressed forwards, just in the interest of time. So if this 2 minutes isn't enough after the first question, I'll just give an opportunity for people to say yes or no. You just type in either the chat or the Q&A whether you think that 2 minutes is enough. So if you haven't already, I would get either minimize us and get up the BNF on your laptop or on your iPad, get your BNF up on your phone if you've got the app, or you can go on Safari or something. I don't think we'll need a calculator for any of these questions, but it might be worth just having your phone handy just in case.
We've tried to write questions that are at the harder end of what you'll get in the PSA, so questions that we would have found difficult when we were doing it. As Holly said, this is totally a learning session, so please don't feel discouraged if you're not getting them, or if you're not really sure where to look for them. That's why you're here. It's learning, and hopefully when we go through them, it'll be a bit more clear.
Okay. I have been asked to allow you to post in the chat, and I'm unsure how to do that. So if anyone knows how to do that, please let me know.
Let me try sending a message in the chat and see if it works. Hello, Holly. Can you see that?
I can see that. I'm not sure. I don't know if it's just because we're hosts that we can.
Oh, it's just me.
Classic Zoom. Oh no. I've found it. Right. Hopefully you guys can now chat.
Nice one.
Okay. So if you just put in the chat when you're done. Yes, perfect. Right. Okay. So giving you a couple of minutes to gather your resources. Once we start going after the first question, if it's an appropriate time, we'll just carry on zooming through. Okay. So I'm just going to set a stopwatch. Have a pen and paper ready and a BNF. Okay. Here we go.
First question. A 70-year-old man is at pre-op assessment for a prostatectomy and is having routine blood tests. He has a past medical history of hypertension, type 2 diabetes, angina, and benign prostatic hyperplasia. His blood results are below. And then there's the questions. Okay, that's 2 minutes. Next question. An FY1 on call is asked to review a 95-year-old man who's had a fall in hospital. This is his third fall this month. He has a past medical history of atrial fibrillation, heart failure, back pain, incontinence, type 2 diabetes, and benign prostatic hyperplasia. First, select the 4 medications which may be contributing to his falls, and then select the prescription error in this list. That's 2 minutes. That's 2 minutes. That's 2 minutes.
Realised I was on mute as well. Sorry, hopefully you can now see the last drug if I... Sorry, that's probably better.
That's 2 minutes.
We'll now be doing 1.5 minutes for the questions. Okay, that's 1.5 minutes. Okay, that's a minute and a half. I'm really sorry, there's no way that I can make this text bigger without getting rid of some of the answers. You'll get the slides afterwards, so even if you just skip this question, you'll be able to have a look at it in your own time. Okay, that's a minute and a half. Okay, that's a minute and a half. Okie dokie. Right, so that's all of the questions done. Let me just check the chat. Okay. So we've managed to answer a fair few questions of the Q&A, but I had to stop because I realised when I was bringing up the Q&A, it was cutting off the bottom answer. So that was what was causing it. So apologies about that question. Hope it didn't ruin your flow. So we'll go through the answers with some explanations and a little bit of teaching. So
first one. So first of all, well done everyone for going through the questions with us. Hopefully you got some of the answers right, but if not, again, it's a teaching session. If you knew everything, you wouldn't need to be here. So let's just go through and see how you did. Cool. So question 1, part A. So this man is having a pre-op assessment, routine blood taking. This is a really common finding. You'll see patients who are completely well coming in, then they have a blood result and you're like, oh, not really sure why that's happened. So select the 2 medications most likely to cause this electrolyte abnormality. Any suggestions in the chat? Anyone feeling confident? Oh yeah, perfect. Oh yeah, awesome. You guys are great at this. So yeah, next slide, Holly. My glamorous assistant. Holly's got all the access to the slides. So if this bit isn't as slick, it's Holly. No, I'm kidding. 2 minds. So brilliant. So bendoflumethiazide and omeprazole are both known to cause hyponatremia. So in this question, this person had a sodium of 127, so a low sodium, and everything else was sort of fine. Okay, cool. Next slide. So thiazide, bendoflumethiazide, causes hyponatremia. And that's just a screenshot of the BNF, so where you can find it. So when you see side effects, it's listed as electrolyte imbalance. So I think someone put in the chat before that often it doesn't tell you the specific electrolyte abnormality. Unfortunately, that is true. Electrolyte abnormalities are sort of just something you have to know. I find it really useful to think about why. So why is it happening? So with thiazide diuretics, how they work is they basically just shove all your electrolytes into your urine to get the water to follow it, because it's a diuretic, which means it wants you to wee. So the way it does that is it shoves sodium into the urine and the water follows. And because you're moving all your sodium out, that's why you get the hyponatremia. For omeprazole, again, there's a screenshot below. With the hyponatremia, this actually does say hyponatremia rather than electrolyte imbalance, and I think this is because there is no reason that I have found why omeprazole causes hyponatremia. It's just a known side effect of it, so I'm afraid I don't have an explanation for that one, but handily it has it in the BNF, and maybe that's why. Cool. So I think someone was asking about how we mark this. I think you get, oh, I can't quite remember how the marking works. Holly, can you remember? I think you get a point per right answer.
Yeah, I think it is. In this section, there's no sort of negative marking, but yeah, a point per correct answer. So in the previous one, if you only got the omeprazole, you just get 1, but if you got both, you get 2.
Perfect. That's quite nice. You have to get both of them. And then second question, select the 2 medications which should be held in this acute kidney injury. So we can tell this person has an AKI because their urea is raised, their creatinine is raised. What do we think? Anyone brave enough? Ramipril, yeah, brilliant. Ramipril, and metformin, great. Next slide, Holly. Yeah, perfect. Ramipril and metformin are the right answers. So, and they're for slightly different reasons. So metformin, one of the really important side effects of metformin is lactic acidosis. So this can make patients really unwell. Metformin is excreted by the kidney. So if you've got a patient who's got a kidney injury, they're not filtering their blood quite as well. So they're not moving the metformin out, which means the metformin stays around and causes that lactic acidosis. So we really worry about that in patients, which is why we stop metformin when someone has reduced kidney function acutely. In CKD, they sort of compensate for it, so it's not as important. But when there's a sudden decrease in renal function, you're prone to lactic acidosis with metformin. So then Ramipril. So with Ramipril, ACE inhibitors can stop glomerular filtration. That's just the way they work, which sort of decreases the blood flow through the kidney and can exacerbate an AKI. So with ramipril, it doesn't cause kidney failure, so you don't need to stop it in kidney failure. But when there's an acute problem, it's best to stop it so you don't get worsening of that kidney function. So just looking at the questions, why not stop the diuretics in this case? So often in questions like this, there'll be there might be a couple of medications that look like the right answer as well, but it's what is most important to stop. So the most important things to stop are the metformin, because it can make you really unwell, and the ramipril, because that's known to really increase the effects of AKIs. If one of them wasn't there, benjo would be the right answer, but in this case, these are the two that are the most important to stop. I hope that makes sense.
Yeah, I think it does. And I think that was a really good explanation. I think sometimes with these PSA questions, it can be quite frustrating because actually there's quite a few right answers. It's just finding the most right of the right answers. And these sorts of questions are really good for clinical practice as well. Every day we're sort of having to suspend medications in patients that have AKIs. So it's a good life lesson as well as for the PSA.
So question 2. This is so common in hospital. Half of what I do on my nights is reviewing people who've had falls, looking at their medications and going, okay, I can see exactly why this has happened. So this could have been me on call after review, a 95-year-old man who's had a fall. This is his 3rd fall. So he's got a few comorbidities, so taking a lot of medications. So select the 4 medications which may be contributing to his falls. Anyone got any ideas? A few good answers. Cool. Holly, should we go to the right answer? So these are the 4 medications in this list that is most likely to cause falls. So a bit of explanation. So first of all, going for amitriptyline. So again, these are just the screenshots where you can find it in the BNF. Just to prove to you guys that we're not lying, but just so you know what you're looking for. So amitriptyline is an anticholinergic, and all anticholinergics have the same side effects, plus or minus other ones, but the anticholinergic sort of burden, they're all the same. And one of these symptoms is hypertension, drowsiness, dizziness. Oxybutynin is an antimuscarinic, which I've always just sort of learned as a sort of different flavour of anticholinergic. So they tend to have the same sort of side effect profile. Oxybutynin is one of those drugs which patients are on quite often, which they don't need to be on still. So you can look at reducing the medication burden, so taking less drugs, just when you're reviewing patients in life. Tamsulosin, I think you guys got. So tamsulosin is an alpha blocker. So your alpha receptors work really hard to vasoconstrict and keep your blood pressure up. So if you're blocking your alpha receptors, you're stopping that vasoconstriction effect, which means your blood pressure can drop quite quickly. In particular, this causes postural hypertension, which just means when you get up from a chair, you're more likely to fall over. And it's quite common in older people. And then benjoflumethiazide. So we spoke about before, the way this works is it pours all your salt out of your kidneys into your urine, and the water follows it. So if you imagine that someone's just taking a large proportion of your blood volume and hoying it into your urine, you're going to feel a bit lightheaded. So dizziness and hypertension, because you've got less fluid running around your body.
Sorry, I can just see someone's raised their hand. Just 1 second. Did you want to speak, Michael? I'll just allow you to speak. There you go.
No, sorry, I pressed the wrong button.
Okay.
No worries.
So some people are asking about cyclizine. So what's the question? So this is a bit difficult because it's really a clinical question. So oxybutynin is known to cause falls in people because of its antimuscarinic side effects, and all antimuscarinics are known for causing falls and drowsiness and dizziness that can make you fall. Cyclizine, although it does have a side effect, doesn't particularly make you fall. It is a difficult question, which is sort of why it's on here, but it's sort of knowing in real life what happens to the patients that take these medications. So cyclozine is an antiemetic that we prescribe to a lot of people, but it doesn't make people fall as often as the antimuscarinics do. So that's sort of the answer for that one. So select the prescription error in this list. What do we think? Yeah, tamsulosin. So tamsulosin is prescribed wrong. It should be 400 micrograms. So this is something that's really easy to miss if you're not looking carefully, because you might look at 4 milligrams and think, oh, that is a reasonable dose, and 4 milligrams is a reasonable dose for a lot of drugs, but tamsulosin is prescribed in micrograms. Yeah, well done, good spot. Cool. Question 3, part A. So this is a lady who's got a new diagnosis of AF. She's considering her anticoagulation options and might be going with warfarin. Select the 4 prescriptions that would interact with warfarin. This is an interactions question. Let's go. So fluoxetine, amiodarone, St. John's wort, and carbamazepine. So the key bit of information in this question is learning about the P450 enzyme system. So the P450 is an enzyme that's made in the liver that breaks down warfarin. So as you'll all know, warfarin is an anticoagulant. So if you've got a lot of warfarin around, that makes you really bleedy, and your INR will be up, because INR is sort of a measurement of how long your blood takes to clot. So if your INR is high, your blood isn't clotting very quickly, so it's very runny. So you've got drugs that can induce or inhibit the P450 system. So the first 2 drugs, fluoxetine and amiodarone, are P450 inhibitors. This means that P450 isn't working as well, so it isn't breaking down warfarin. This in turn means that you've got more warfarin swimming around, which makes you more bleedy and increases the INR, so you get more bleeding. For inducers, the reverse is true. So St. John's wort and carbamazepine are both P450 inducers. That means the enzyme is working better, which means warfarin is broken down more readily. So you've got less warfarin around, which means your INR is lower because your blood's taking less time to clot. I hope that makes sense. It's a difficult thing to wrap your head around, but it's a common exam question, so it's worth spending a bit of time understanding P450. Next slide. So yeah, that's just sort of what I said, reiterated on the screen. And just some mnemonics to remember what induces and what inhibits. So sickfaces.com and crap GPs is what I used. Yeah, it's sort of just one you have to memorize, but they do like asking questions on it, so I think it is worth your time just going through it a little bit. And then select the medication on this list which is prescribed incorrectly. Any guesses? It's a bit of a hard one. Yeah, so well done. Who was it? Rosie. Yeah, so simvastatin, 20 milligrams. So the problem with this is statins are prescribed overnight. So next slide, Holly. So the prescription should be once daily dose taken at night. So when this is written out, it should say ON rather than OD. The reason this happens is all the cholesterol activity in your body happens overnight when you're sleeping. So giving the drug that sort of stops the cholesterol pathway in the night is better because it's working. It's working at the right time. It's actually stopping it rather than it being in your system all day, getting broken down. Then the actual cholesterol activity happens overnight and you've got nothing to stop it. So yeah, so just in the chat, just saying ON is in the night, OD is once a day, OM is in the morning. Where are these questions from? These questions are from my brain. We don't take them from anywhere. This is Thursday 15 original you're being treated to. Yeah, we'll send you the slides out afterwards.
If it helps, sorry, just going back to the OD, ON, all of these are Latin abbreviations. So ON stands for whatever the O stands for. In my mind, it stands for once, but I don't think that's Latin. The N stands for nocte, so once at night. OM is once mane, which is once in the morning. And OD is once daily, but in Latin, where the same name begins with D. And same with like QDS, that means 4 times a day, but in Latin.
Would you get the mark if you wrote nocte? It's like a tick on the PSA, it's all ticked, you don't write anything for prescription review, but you would get the mark, yes. Why is amitriptyline prescribed at night? Why is amitriptyline prescribed at night? Because it has side effects such as falls and sort of nasty side effects like that. So patients tend to like it at night because during the day they can get a bit drowsy and dizzy. So if a drug does have those sort of side effects, it's quite good to prescribe them at night. So the patient should be in bed asleep rather than wondering about falling. But in actuality, that doesn't always happen. Why is folic acid correct? The patient could be pregnant. We don't know that she isn't. That's the right dose in the BNF. Cool. Question 4. So a 55-year-old lady is reviewed in the ward for tachycardia. She feels sick, weak, and has some chest pain. She has various past medical histories, and her investigations show tall tented T waves. So the phrase tall tented T waves should immediately bring something to your mind. And that something should be, is anyone going to put it in the chat? Hyperkalemia, yes, perfect. That is a real trigger phrase that is worth knowing. If a question says tall tented T waves, they want you to think about high potassium. In actuality, patients don't always have tall tented T waves, but I saw an ECG with tall tented T waves on the other day, and it was straight in my head, hyperkalemia, we need to manage this. Okay, given that, which 2 medications should be held acutely? Oh yeah, you guys know this one. So spironolactone and ramipril. So ramipril and spiro both have side effects of hyperkalemia. It's a very common electrolyte imbalance in hospital. I'm constantly, and I'm sure Holly is, I'm constantly suspending ramipril and restarting it. And spiro is a potassium sparing diuretic. So if someone has a lot of potassium on board, the last thing you want to do is keep more of their potassium in their body. So you'd stop that as well. Cool, next question. Part B, select the prescription error. What do we think? Oh, you guys are good. You were listening to Holly's tip about once daily, once weekly. Yes, perfect. Methotrexate is prescribed once a week rather than once a day. That's really, really important. If you give methotrexate once a day, you will overdose someone. It's really easy to get mixed up when you're prescribing in hospital, clicking that once daily rather than once a week. But it's really important, and it's something that they probably will test, just because it is so important, and it's an easy way to catch people out, and they're always looking to catch you out. So yeah, and it's quite easy to sort of see 7.5 and think that's the right dose, that's the right answer, but make sure you're looking at how often it's prescribed. How do you write once a week? They'll probably just write out in words once a week, but if they write like OW, I imagine that's once a week. Yeah, and just as a note, most patients take it on the same day every week. So a patient will tell you they take methotrexate on a Monday. They often know what they're doing. Cool. Next, a 70-year-old man presents with an intra-abdominal infection. This is another really common scenario in hospital. I've got a patient who's got an infection and they are constipated. Half the patients in hospital are constipated, so it's really important to look at their medications and see what might be making it worse. So 2 medications that are most likely to be contributing. Oh, I meant him, sorry, not her. Oh, perfect. Yeah, you guys got this. So the answers are codeine and ferrous fumarate. So importantly, a lot of medications on the BNF will have side effects of constipation, and they will probably give you medications more. If they ask this question in the PSA, they'll probably give you a few drugs with side effects of constipation, but it's sort of your job as future doctors to know which ones are more constipating than others and which ones we would in practice stop, because you can't always stop every medication a patient's on. A lot of them are important. You don't want to suddenly suspend them all, but it's your job to work out clinically, okay, which one is most likely to be causing the constipation. And I think that is the point that I try and impress on you the most. And often in the PSA, you'll see that there's a few right answers, but actually it's your job to know clinically which ones are the most right, if that makes sense. So codeine. So opioids are so constipating. This is a really important thing to know and something they'll probably test. When you prescribe opioids in hospital, you should always prescribe a laxative as well, just so the patient has the option of taking a laxative because they're very constipating. And then ferrous fumarate, also really constipating. And those are the 2 drugs that I've come across the most in clinical practice that are really constipating. So yeah, very important. Cool. Select the medication which should never have been prescribed for this patient. What do we think? Yeah, awesome. Metoclopramide. So this patient has Parkinson's disease. So they do not have enough dopamine, or they're not using their dopamine properly. The last thing that we want to be giving this patient with Parkinson's disease is a dopamine antagonist, because this will make their Parkinson's disease so much worse. So never, ever, ever prescribe metoclopramide for Parkinson's patients. That's a really important point to get across. Metoclopramide, interestingly, has a sort of sister drug called domperidone, which is a similar sort of thing. But importantly, metoclopramide crosses the blood-brain barrier, whereas domperidone doesn't. So because metoclopramide crosses to the brain, you cannot use it because it'll make your Parkinson's worse. Question in the chat, what about amlodipine? It commonly causes constipation too. So as I said, a lot of drugs cause constipation. I mean, I wouldn't be surprised if it's in 80% of the side effects lists on BNF, but it's about knowing which ones are the most constipating. So clinically, where do we see constipation the most? And that sort of things you'll pick up from talking to doctors, being on the wards, talking to patients. But I wouldn't worry too much. I think if you get one of the marks, then it's fine. Again, the PSA is pass or fail. So as long as you're getting most of the answers right, you'll be fine.
Okay, so moving on to the planning management stage. So this is a 27-year-old female who attends her GP surgery complaining of a burning sensation when she urinates, alongside increased frequency and urgency of urination. So already in that first sentence, we should be thinking of a diagnosis. She's 32 weeks pregnant and she doesn't take any medication. On examination, she's comfortable at rest, suprapubic tenderness, no renal angle tenderness. Okay, and she's got a positive urine dip. So put in the chat, what is the most appropriate management option at this stage? Okay, so quite a lot of you have gone for nitrofurantoin. So let's have a look. Cefalexin. This is where I hope that I've looked in the BNF correctly. So the key thing to recognize here is she's 32 weeks pregnant. So that's nearly at term, and that's in the final trimester. So obviously she's got a UTI, but we can tell she's not got pyelonephritis. Well, it's insinuating she's not got pyelonephritis because there's no renal angle tenderness. And she's pregnant and nearly at term. So to get this on the BNF, if you type in urinary tract infections, the guidance has actually changed since we did it last year. So even if you think you know the guidance off by heart, I would always advise double checking if you've got time. Obviously, if you don't have time, just go through it straight away. If you have time, look it up in the BNF. So if you go into urinary tract infections under pregnant women, oral first line is nitrofurantoin. So I can understand why you've put nitro. However, if you actually go down to the side effects of nitrofurantoin, it says avoid at term because it may produce neonatal hemolysis. So thought term was from 37 weeks. Can you not use trimethoprim in the third trimester? So I would just term probably, okay, fair enough, term probably is 37 weeks, but they often do these questions to try and separate. Traditionally, it was to separate whether you're prescribing trimethoprim or nitrofurantoin. I probably should have altered the question to make it 37 weeks, but I would say as this is in the final trimester, I would avoid nitrofurantoin here. You want to be really careful when you're prescribing for people in pregnancy. So then if you go back, second line is then amoxicillin, but that says only if the culture is susceptible. We don't have a culture here, so it's not going to be amoxicillin. And then we go to cefalexin. And we look at the dose of cefalexin, which is 500 milligrams twice a day for 7 days. So that is our correct answer for that. I can understand why that might have caused a little bit of confusion, but I would just bear in mind that anything really third trimester onwards, I would kind of call that term in my own mind, and hope that makes sense. So yeah, trimethoprim is only a risk to pregnancy in the first trimester, but you've got to follow the sort of treatment pathway in terms of first line, second line, third line, according to the BNF. The guidance previously was whether it was nitrofurantoin or trimethoprim, but trimethoprim's become more resistant to antibiotics in recent times, which is why it's kind of fallen off the guidance. So question 7. This is a 27-year-old man who presents the ED having taken a deliberate overdose of 30 paracetamol tablets 6 hours ago with alcohol. He's complaining of nausea and abdominal pain. He's got a past medical history of anorexia. So his OBS are pretty much okay. He's maybe slightly tachy, maybe slightly hypotensive. And his upper abdomen is mildly tender. He's got a raised ALT, borderline, but normal prothrombin time, and any level of paracetamol is abnormal unless you've just taken paracetamol. So what is the most appropriate management option at this point in time? Okay, yeah, great. So NAC, N-acetylcysteine. So as I said earlier, if you're trying to find overdoses within the BNF, the best thing to do is to search for poisoning, and then it gives you the treatment algorithms for different types of overdoses. One of them is paracetamol, and the key thing here, as someone's pointed out, is that he's taken it 6 hours ago. So for pretty much everything, if you've ingested an overdose of something, you can give activated charcoal within the first hour after the overdose. However, we're now 6 hours, so the efficacy of activated charcoal is not going to be great. He has a raised ALT, paracetamol level, has vomited and has abdominal pain. Now, in the poisoning section under paracetamol, there's what's called the paracetamol overdose normograph, which is essentially a graph and a line. And if your paracetamol level is above the line, you treat with N-acetylcysteine. However, he's clearly symptomatic and he's got a high level of paracetamol. So without even looking at the normograph, you can probably guess that he's going to need some treatment with N-acetylcysteine. So sodium bicarbonate you can use in other overdoses, particularly tricyclic antidepressants, and naloxone is used in opioid overdose. Diazepam, as far as I'm aware, isn't used in overdose, but might help with symptoms of overdose. Okay. Now, apologies, I do realise that the text is quite small on here, but hopefully you've deduced that this is a young lady with type 1 diabetes who's lost her appetite during her illness, so hasn't been taking her insulin. She's now got a reduced GCS, she's hypotensive, she's got an increased rest rate, she's got ketones and glucose on her urine dip. If you look through her bloods, you probably spot that she's got a low pH, and she's started fluid resuscitation with sodium chloride. So that's quite a lot of information. But given the likely diagnosis here, what do you think the most appropriate management option is at this stage? Yeah, perfect. So what you want to start when somebody is in DKA is you want to start aggressive fluid resuscitation, which is why I've already put that fluid resuscitation has been started, and then you want to start them on some insulin. because otherwise their glucose isn't going to come down. Obviously, you would also, no, I'll stop that. Okay, so she's in DKA. She's hitting the 3 criteria of DKA. She's acidotic, she's got ketones, and she's got a raised BM. This treatment, the treatment for this is insulin. I tried to have a look on the BNF. I couldn't actually find dosing during DKA, which is why I put this on, because I think this is just something that you need to learn the dose of. It's 0.1 units per kilogram per hour. And you could get asked about it again. I think it is unlikely you would be asked to physically prescribe it, but I think it is realistic that it would be an option. In reality, when you're in hospital, all of this is on a nice chart for you, set out, and really helpfully laid out, because obviously this is an emergency situation. So I've just seen a question about, in the PSA, are you allowed to click on the useful resources link? I think all other sites are banned apart from BNF, some sections of NICE, and the actual exam website.
Yeah, when we did it, it was only BNF you're allowed to use, so you weren't allowed to use like NICE, CKS or anything like that. Those websites aren't actually locked, but I would say it's not worth the risk using other websites in case someone catches you and you then get disqualified from the exam. And the BNF should have everything you need anyway.
Great. Yeah, so as I said, you can look it up in the BNF and it just says to consult your local protocol, which is usually, as I said, 0.1 units per kilogram per hour. Okie dokie. And second to last one, we're nearly there, guys. A 75-year-old man is admitted to hospital with shortness of breath and a cough productive of green sputum. He's got hypertension, type 2 diabetes. He's got a 60-pack year smoking history, and he's on a bunch of medications. You hear a widespread expiratory wheeze. He's got SATs of 96, and he's got hyperexpansion in the lung fields. So what do we think is the most appropriate management option at this stage? Okie dokie. So I think you're a bit split between 3 and 5. So I think we're all getting that the hidden diagnosis here is that this chap has COPD. He's not got a formal diagnosis of it, but he's got a 60-pack year history. His GP obviously thinks something's wrong because he's on a salbutamol inhaler, PRN. He's got hyperexpansion of the lung fields on his chest X-ray, and he's got a widespread expiratory wheeze. All of these are coming together to make a diagnosis of COPD. Add on the infective symptoms, we're getting an infective exacerbation of COPD. So treatment is with antibiotics and nebulizers if wheezy, and oral or IV steroids. Now, he's already been started on amoxicillin by his GP, so we don't need to give him antibiotics. He's wheezy, so we're going to give a nebulizer, and it could be, nebulizers can be given through oxygen or through air, but his SATs are 96%, so they're good, and we don't know whether he's a retainer or not. So that's actually an appropriate level at the moment, given that we've got no proof that he's a retainer or not, so he doesn't need any surplus oxygen. So we can give that salbutamol nebulizer through air. Now, given this isn't a severe attack, he's only got a small increase in his rest rate. He hasn't decreased his SATs. He's got no hypotension. There's no mention of his GCS reducing. He doesn't actually warrant IV steroids at this point in time. He would probably be started on some oral prednisolone, but he doesn't actually warrant the IV hydrocortisone, although obviously that is appropriate, just not for this particular patient or the severity of the attack. Just looking at the chat. So the oxygen, 15 litres via a non-rebreathe. We want to aim for SATs above 96% or above, and he's at 96%. So what you don't want to do is pump someone, especially with COPD, full of loads of oxygen and deplete their hypoxic drive for breathing, and essentially accidentally make them stop breathing. So if the patient was deteriorating, the first choice would be hydrocortisone, if not salbutamol. I think you need to go back to your A to E assessment. Obviously, we start with A for airway and B for breathing. You're going to get to the wheeze, and the thing that's going to stop the wheeze is the salbutamol nebulizer in all reality. The hydrocortisone will help sort of longer term with dampening down the inflammation, but in terms of getting this guy to breathe, he needs the salbutamol nebulizer. Is it common for a patient to be afebrile in infective exacerbation of COPD? People can be afebrile whilst they've got an infection. In order to have made this question a little bit easier, I probably could have made him have be pyrexial. But absolutely, we see plenty of patients that we're treating for sepsis or infections, and it's only in really severe cases where they tend to actually really spike their temperature. Let me just have a look at what I've, 37.0, okay. In this question, I was hinting that we didn't need to put him on antibiotics because he was already on amoxicillin. Even if it was a non-infective exacerbation of COPD, you would still be looking at giving salbutamol and then steroids if it's very severe. So it doesn't actually change the management in this case. So question 10, final one. A 57-year-old man attends his GP after completing home blood pressure monitoring. He's got diabetes and CKD3. He's on metformin. His average reading is 156/90, and he's got a creatinine clearance of 40 and a GFR of 44. What's the most appropriate management option at this stage? Okie dokie. So most of you are pretty much there. It is ramipril, but it's this number 2 option of ramipril, which is 1.25 milligrams once a day, increased up to 5 milligrams once a day. And how we found this, so do you remember your guidelines for choosing antihypertensives, so the ABCD guidelines? So at the top branch, it's separated into different sections depending on age, ethnic origin, and also whether a patient has type 2 diabetes or not. You can find this by going into the BNF, into the hypertension section. So I've just, hopefully you can see that I've highlighted. So this is hypertension in, let me try and find, hypertension in a patient with type 2 diabetes in any age or origin. Step 1, offer an ACE inhibitor or an ARB. And then if we go into ramipril, we can see it's initially 1.25 to 2.5 milligrams, increased up to 10 milligrams. But if we remember, this chap has CKD3 and he's got a creatinine clearance of 40. So it's a maximum daily dose of 5 milligrams if a creatinine clearance is 40. So sometimes these questions have multiple steps to them, and it's important to consider all of the comorbidities when you're looking at prescribing. Okay. The answer to question 9 was salbutamol nebulizer. Okay, so in summary, for the planning and management section, and for the prescription review section, use your clinical knowledge to start with to give you an idea of the answers that you think are likely to correct, and then back this up with the BNF. It's particularly important in the prescription review section, where you might know that there are multiple correct answers and you need to use the BNF to find the one that has the most common side effect. If unsure, I would, for the planning management section, start with the treatment summaries, look up hypertension, poisoning, urinary tract infections, and always bear in mind allergies, comorbidities, and relevant blood tests.
For prescription review, I'd say make sure you know the side effects of medications that are prescribed really commonly. So stuff like hypertension medications, heart failure drugs, things that you come across commonly in practice, so know their side effects. And if you get a bit worried that a lot of the drugs have the same side effect, go for the one that you know causes it the most, but don't be too hard on yourself. No one gets 100% on the PSA, and you don't need to get 100% on the PSA.
Okay, so thank you so much for coming, guys. Thank you for engaging. We are plodding through your questions on the Q&A, and we will write an answer to every single one of those. If you can scan the QR code.
I'll pop it in the chat as well. There's been a few questions about, can we have the slides from last week? So Thursday 15 is an organisation run by junior doctors, and a different junior doctor presents every week. This means that the feedback is tailored to that doctor, and we send the slides and recordings out to people that have given feedback on that doctor. Unfortunately, we can't send their materials out without them getting feedback. So I'm really sorry about that. If you've attended all 5 PSA sessions and have just missed one, we might be able to send the slides out at the end. But I hope you understand we have to keep those people's materials sort of protected as well.
Angie, just responding to your question, we weren't at the previous session, so I'm not 100% sure of the resources that were mentioned. Ones that I found particularly useful were the official ones through the official PSA website. I think it's technically the BPA website. I know someone was struggling to Google it earlier, so I'll try and Google it now. But they're the ones I can definitely recommend, but they're limited, so just be aware you don't want to use them all up in advance of time.
Just another question. If you fill in the feedback, you'll get the recording. Yes. If you fill the feedback form in, you will get the slides and the recording. There are more of you than we anticipated being here, and so please just bear with me while we collect all the email addresses, but I will send them out this week. That's a promise. With the pass mark, so it varies for every exam. The pass mark is sort of moderated to how well people do on it. It is normally between, I think, about 50 and 65%. It's not crazily high. So I would really stress, try not to worry about this exam. I mean, you were all answering the questions really well today. So I'm sure you'll be fine.
So I've just gone to Google the BPA and I've realised we've made a spelling mistake and we're getting confused with our 3-letter acronyms. It's BPS. That might help you. I think it's the British Pharmacological Society who run the prescribing exam.
Yeah. How many times do you recommend doing the past papers? I'd probably do them when you feel like you've revised. When you feel like you know quite a lot, then it's the time to do them, because there's not that many. And I personally prefer not to use them for practice, and I prefer to use them for when I think it'll be a good representation of the mark I'll actually get. But I know some people like to use them for practice, and if you do use them for practice, you can sort of get an idea about, you know, what drugs do what. But I feel like doing the same paper more than twice won't be helpful, because you'll know all the answers already, so you're not really testing your knowledge. Where can I find the recording / slides for the webinar? When you fill the feedback in, they'll get sent. There's a question about, do we get given multiple insulin doses on the multiple choice, and if so, where do we find it on the BNF? So insulin is a drug that is very much tailored to the patient. It's very specific to the patient. They would not give you examples like Nova Rapid 10, Nova Rapid 12, Nova Rapid 14 without you knowing what the patient normally takes. There might be a question where he takes a dose of insulin and they tell you that his BMs, so his blood sugars, are really high, and you might have to know, do I increase it, decrease it, or keep it the same? I think asking you to moderate insulin with no information would be far too unfair. So you probably won't find doses for insulin on the BNF because it's very patient specific.
Yeah, and specifically for DKA, that is a set dose that's used almost universally, but different trusts might vary it very slightly. So remembering that set dose is not gonna, you're not gonna go wrong with that set dose for DKA in the BNF. I think it would be very unfair of them to give you different rates of an insulin infusion for DKA when it doesn't explicitly say it in the BNF. But I don't think it would be unfair to have a question like we had earlier.
What score should you be aiming for in the PSA? So the PSA is purely pass or fail. So you want to be getting above the pass mark. So I think if you're comfortably hitting sort of between 65 and 70% of your practice papers, that should be enough. And I know that a lot of you will have finals to revise for at the moment, and it's really tough just throwing another exam on the pile to make you do. But as long as you're hitting sort of nearly 65, 70%, that's probably what I'd aim for. Yes, fluoxetine is a P450 inhibitor. In sick faces, the F can stand for fluconazole or fluoxetine, so you can remember it that way.
So we will find out whether the Stockley's interactions checker is officially banned or whether this is hearsay. I wasn't aware of it, but also I'm not in 5th year about to take the PSA. It was certainly allowed for our year, but I would err on the side of caution and perhaps don't rely on using it, but get to know how to use it, if that makes sense. But we'll find out, and I'm running the session next week, so I will update people if they come back next week.
The interaction function on BNF does work. So if you go to the page for the drugs, if you go to ramipril, then you click the interactions icon, the interactions little hyperlink, it'll take you to the interactions page. Interactions wise, they'll probably ask you common interactions and well-known interactions, so try not to get too bogged down on it. Tips on identifying drug errors. Most commonly, it'll be a fatal drug error. So I would look for something that looks dangerous. So, for example, it might be like a factor of 10. So if you know sort of roughly what the drug dose is. So for example, ramipril, if you know that it's about 5 milligrams and you see, 2.5 milligrams, that probably isn't a prescribing error. But if you see 500 milligrams, that is. So try and look for things that look out of the normal, or look for, if it's once a day, once a night. But when you have more experience with these medications, you'll recognize what's right and what's wrong a bit easier. But you can find the doses under the indications part of the BNF on the drug page.
So I didn't use mine, use a safe exam browser. I don't really know what one of those are. We were essentially free to log on to anything that we want. But there were invigilators coming round and looking over our shoulders. I don't know about you, Alex.
Yeah, we were all sat in like a big room with lots of desktops, and you could just log on to whatever computer you wanted. But yeah, as Holly said, there's people walking around, and they know what websites you're meant to be on, what websites you're not meant to be on. So they do know what to look for. Just on that note, it's quite good to, I think I said before, but it's quite good to practice using the computer and to be on. I hadn't used like one of those really old computers in ages, so just sort of familiarising myself with it before the exam was quite helpful.
Okay. All right. Great. So thanks so much for attending. I think we will log off.
That's all the questions, yeah. And
Great.
thanks so much, guys. Keep an eye out for the slides in your inbox. And see you next week, or on Thursday for our oncology session for finals.
Probably should have plugged that a bit more. All right. Thanks.